In today's session, we will explore galactorrhea, a condition characterized by inappropriate lactation or discharge of milk-like fluid from the breast in individuals who are not pregnant or beyond the postpartum lactational period. We will review its pathophysiology, clinical manifestations, diagnostic workup, and treatment options. Let's begin. Galactorrhea refers to the production and expression of breast secretions resembling milk, persisting more than 6 months postpartum, or occurring in individuals who have never been pregnant. The underlying pathophysiology often involves elevated prolactin levels. Prolactin is secreted by lactotroph cells of the anterior pituitary gland. Dysregulation in dopaminergic control can precipitate elevated prolactin concentrations, leading to galactorrhea. It is worth noting that dopamine under normal physiologic conditions normally inhibits prolactin release. Hyperprolactinemia can have multiple causes. Pituitary adenomas, specifically prolactinomas, pharmacological agents such as antipsychotics and certain antihypertensives, hypothyroidism, or direct chest wall stimulation. In rarer instances, the etiology remains uncertain, and we call this idiopathic galactorrhea. So what are some of the clinical manifestations? These include nipple discharge. This is often bilateral, spontaneous, or even expressible. And frequently there is a milky discharge which can vary in color. Menstrual disturbances in females, where they present with amenorrhea or oligomenorrhea, secondary to hyperprolactinemia, induced suppression of GnRH. Infertility occurs due to anovulation or luteal phase inadequacy. In males, they may develop hypogonadism. This presents with reduced libido, erectile dysfunction, or even subtle galactorrhea if prolactin is markedly elevated. There are a few other symptoms that can happen, and these include headaches or visual field defects, specifically bitemporal hemianopsia, if a pituitary macroadenoma compresses the optic chiasm. Osteopenia or osteoporosis can also occur with chronic hyperprolactinemia, and the reason for this is that prolactin actually inhibits the production of sex steroids. So what are some of the causes of hyperprolactinemia? These may include pituitary lesions. Specifically, prolactinomas are the most common functioning pituitary adenomas associated with galactorrhea. But other causes of hyperprolactinemia may be non-functioning pituitary adenomas. And this is because they can elevate prolactin by compressing the pituitary stalk, a phenomenon known as the stalk effect. This actually impedes dopamine's inhibitory action on prolactin release. There are some pharmacological inducers of hyperprolactinemia as well. These agents block dopamine. Example would be antipsychotics, phenothiazines, etc. And this increases prolactin secretion. There are some antiemetics, such as a common one would be metoclopramide, which also exhibits similar effects. How about thyroid dysfunction? Well, in patients with primary hypothyroidism, there is elevation of thyrotropin-releasing hormone, which stimulates both TSH and prolactin release, potentially causing galactorrhea. In patients with severe primary hypothyroidism, they may present with galactorrhea, and treatment of the primary hypothyroidism with thyroid hormone replacement completely reverses the galactorrhea. So in those patients, really there isn't a rush in starting them on any agents to stop the galactorrhea, just providing the patient with reassurance and letting them know that they should start their thyroid hormone replacement and that their breast symptoms would resolve is enough. Another important cause of hyperprolactinemia is chest wall irritation, so chronic irritation or excessive manipulation of the nipples, as well as certain neurologic thoracic lesions like zoster infections, etc., can upregulate prolactin secretion reflexively. And then in some cases, it's just idiopathic. So in this subset of patients, there's no specific etiology isolated, yet there is mild hyperprolactinemia and sometimes galactorrhea. So what is the approach to diagnostic evaluation? Well, it first starts with a clinical history and physical exam. So we need to evaluate discharge characteristics. Is it bilateral versus unilateral? Is it spontaneous or only occurring on expression? Furthermore, it's important to take a detailed medical history, a reproductive history, and potential systemic symptoms such as headaches and vision loss. And an important laboratory evaluation would be the serum prolactin, and this is the cornerstone of galactorrhea evaluation. Markedly elevated levels greater than 200 nanograms per ml strongly indicate a prolactinoma. As we mentioned earlier, it's important to exclude primary hypothyroidism. For this reason, thyroid function tests, specifically TSH and free T4, should be checked in these patients. Renal and hepatic panel, since chronic renal and hepatic disease can alter prolactin metabolism. And then, in females, checking a beta HCG is required for any patient of reproductive age presenting with female patient of reproductive age presenting with galactorrhea. So imaging includes MRI of the sellar region. It is indicated if prolactin levels are significantly elevated or if there are neurological symptoms suggesting a mass lesion. Mammography or ultrasound is required to rule out breast pathology if indicated by clinical suspicion, especially in patients where pituitary imaging is negative. So the management of hyperprolactinemia involves addressing the underlying cause. So for example, if it is medication-induced, example in patients on antipsychotic agents, it's important to consider adjusting or discontinuing the offending agent in consultation with the patient's psychiatrist. In patients with primary hypothyroidism, correcting the hypothyroidism with levothyroxine normalizes the TSH and reduces prolactin levels. So in patients with known prolactinomas, then there is medical therapy for these patients. So dopaminergic agonists such as bromocriptine or cabergoline are first line for prolactinomas. These medications lower prolactin levels, alleviate galactorrhea, and restore gonadal function in patients, and most importantly, will cause some adenomas to shrink. Surgical intervention is actually reserved for macroadenomas. These are tumors greater than 1 centimeter in size, with evidence of mass effect and unresponsiveness to medical therapy, or if a patient cannot tolerate dopaminergic agonist. The transsphenoidal resection of the pituitary lesion is typically preferred. How about observation? Well, in patients with idiopathic or mild hyperprolactinemia with minimal symptoms, regular monitoring may be okay, particularly if fertility is not a concern and no pituitary mass is evident. So these are some useful clinical pearls. Galactorrhea is often a sign of elevated prolactin. Always assess for pituitary etiologies. Medications that have been prescribed for the patient could possibly be the cause. And most importantly, also check for hypothyroidism, because this is often missed. So checking a TSH and free T4 to rule out primary hypothyroidism. Persistent or unexplained galactorrhea warrants imaging of the cellular region to exclude tumors. Dopamine agonists are highly effective in normalizing prolactin, controlling symptoms, and mitigating the adenoma size. Monitor bone health in chronic hyperprolactinemia, as prolonged hypogonadism can lead to osteoporosis. Remember that estrogen is required for bone function. So in patients with elevated prolactin levels, which feeds back on GnRH secretion, reducing the production, eventual production of sex steroids, estrogen levels will be low in these patients. And for that reason, they are at risk for low bone mineral density. Thank you for joining me on this lecture on galactorrhea. Understanding the pathophysiological mechanisms, diagnostic steps, and treatment approaches is essential for optimal patient care. Remember to look for these subtle clinical cues and always consider galactorrhea's broad differential diagnosis. If you found this educational or have any questions, feel free to reach out for clarification. Until next time,